So with my colleagues, Peter Derle, Christopher Mudry, and Gabe Apley, we have been thinking about how to use testing and actually random testing to accompany the exit from the lockdown that is imminent. There's a preprint online that you find on CondMat and also on the Med Archive. And please feel free to ask questions during the talk if something is unclear. And I want to emphasize that this is a simple theoretical physicist approach and not an epidemiological approach. And we just want to show how statistical random sampling can save lives and costs to society. So it's a win-win if we do that. Actually, it costs a little bit something, but we get out a lot. Okay. So you can ask also in German or French if you feel comfortable. So let me start with the simplest epidemiological model that there is. It has very fundamental ingredients, namely a susceptible fraction of the population that can get infected, and then it recovers or maybe dies with certain rates, beta and gamma. And this is captured by differential equations that tell you how the susceptible people evolve. The healthy people decrease in time proportional to their number and proportional to the number of already infected people. The infected increase because they get more infected with this rate beta, but they also decrease because they get healthy, and then the healthy or the recovered increase just because infected people get healthy. Okay, that's very, very elementary. We now focus on this evolution of the infected people, and we are interested in a situation where the susceptible fraction of the population is still large as it is now. So this is essentially 1, and I now actually show you that what is important is the fraction of the population that is still healthy, and here is the modified coefficient now. So this is the basic infection rate, this beta, and the gamma is the recovery rate or death rate. Or also if you detect somebody who is infected and you quarantine him or her, then it goes out of the actively infected population, it becomes essentially inactive. So that's also in here, okay? And here, as I said, is the susceptible fraction of the population, and that's the infection rate. Now, how can you influence or what happens in this equation? So this basic infection rate beta can be influenced if you impose physical distancing, or if you reduce the economic activity, or if you have a full lockdown, right? And the beta decreases. The susceptible fraction of population you can affect if you have immunization. So if you have a vaccine that comes up. Right now, this fraction is so close to 1 that it doesn't matter that some people have already been infected in most places. Maybe New York is an exception or so. Now here, gamma is comes from recovery death that we cannot influence very much other than by therapy, but detection and quarantine you can influence. You can do contact tracing, so you chase the people that have been in contact with somebody you know is infected, and that can increase the detection rate in the quarantine. Or you can even do mass population screening, and then you detect people also very efficiently. Okay. Now, the essence of this simple equation is that the infected fraction of people increases in time with some simple linear equation, and this gives you exponential growth or decrease with a rate that is this k here, this combination, which depends on time. Okay, because gamma may depend on time, beta may depend on time, and also this may depend on time. But for short times, you can take this as a constant. If you do nothing, so if you have unmitigated development of the disease and you are at the start of the disease, this K0 is, this takes a certain value, and this is pretty large, that this is famous doubling in 3 days roughly, and so this K will take the value of 0.23, which is log 2/3. Many people prefer to talk about the reproduction number, that is the number a given infected person will infect during being sick. And that's simply related to this rate here linearly in this fashion. R0 is basically just the ratio between this beta bar and gamma, and is given by 1 plus K0 over gamma, and roughly equates to 3. And the gamma is the inverse of the serial time, basically. So it's about 10 days, 10 or 8 days. Now, as I said, if this rate here turns out to be positive, or what is the same if R is bigger than 1, as you always hear in the media, then you get an exponential explosion. That means the number of infected people raises exponentially, and it only stops when a good fraction of the people is infected. And that's a huge disaster, as you know, because a fraction of the infected will have to be hospitalized. There are only so many beds, and that is a disaster. So we can't afford that. If we manage to get this negative, then the number of infected people decreases over time, as it does now. But actually the stable situation is when we have this rate equal to 0, and therefore the reproduction number equal to 1. That is sort of the marginally stable situation that we are aiming for. Why? Because this is on one hand stable, meaning not exponentially exploding, but also it requires the least restrictions, say on the beta here. If K is negative, you have imposed sort of too many restrictions if you want. So you're aiming for this condition of stability at an as low prevalence or infection fraction as possible, okay? And the question is, how do you get there, and how do you get there most as quickly as possible? Now, as I showed you, you can use testing to influence various of these coefficients, and therefore change the K value. You can use testing, obviously, or you have to use testing to diagnose patients, and you have to also test medical staff to protect them, and that's out of question that you need tests for that, and this is not part of our discussion here. So you always have to set aside enough tests for this use. But then you can use testing in two ways to improve the situation. You can try to suppress this growth rate by testing, either by contact tracing, which is talked about a lot today. This digital contact tracing, especially with the new app that is coming up. And there you try to fight the asymptomatic spread that is very difficult to control. But if you find enough people that have been around an infected person, you can hope that you may get a hand on at least a part of the asymptomatic spread. What you can also do, and this is an interesting proposal, but maybe a bit far out of reach, is a massive screening of the entire population, or maybe an entire subpopulation in small regions that I will briefly discuss first. But then the main point of this talk will be the monitoring of this growth rate. So we said we would like to get to a situation where K is 0 or R is 1, but how do you know that you are there? And here is exactly our idea. We want to propose that, well, eventually you will roughly know what is R or what is K. You read it in the newspapers, but they only can tell you what happened like 3 weeks ago. And that is often far too late to react. In particular, if something drastic is happening and you're not aware of it and you react 3 weeks later, then you have already a disaster in your house. Now we say that you can measure this K, this growth rate, via random sampling and thereby act much faster. And so you can assess your policies, your releasing restrictions with a minimal delay. And then you can use this knowledge of what K is currently to do feedback. So you take back certain restrictions or you optimize your policy measures. Now it's not about saying you should do monitoring rather than suppressing K. You should do both things at the same time, and you have to find the best balance of where to use your test capacity. In a sense, the approach 2 monitors the success of approach 1. Okay. Now let me first talk a little bit about this idea of massive screening of the entire population, which is interesting and maybe at some point in the future will be possible. So the idea here would be not just to measure what is the growth rate, but to affect the growth rate by identifying and quarantining infected households below a serial time. So you want to detect that somebody has been infected before he infects somebody else, or he or she. And if you manage to do that on average, that you quarantine somebody before he infects somebody else, you get the reproduction number below 1, and therefore the growth rate becomes negative, and that's what you want to achieve. But what does that mean in practice? It means that you have to test every household. That's the smallest kind of unit, the atom. You have to test every household once per about 6 days, because in 3 days, typically you infect somebody else. So if you test within 6 days, then your expected value of detection after infection is 3 days. And so you will infect at most 1 person, right? So for Switzerland, that would mean that you have to test 700,000 households every day. And in the US, it's in the millions, okay? Now that looks absolutely daunting. How can you carry out such large numbers of tests? Now here I want to share an old idea that in some sense I knew about, but had completely forgotten. But I think about this, and then it came up when I saw a paper suggesting this massive screening. It's called pool testing. So the idea is that if you have a big population, you want to test everyone, and a few are infected. Now you don't test everyone separately, but you throw samples, say, of saliva of each person together in groups like these columns, and then you test only the column mix. And if it's positive, you mark the column. Then you do the same for the rows, and then you only go to the crossroads of the rows and the columns that have lighted up, and there you test again. And if you do this optimally, and you have a low prevalence, prevalence means infected fraction of the population, which I call I0 always. If this I0 is very small, say 1 in 1,000, then you have to test much less than the number of people here. For example, here you can do basically, well, I think I made a mistake here. You would have to measure 6 and 6, and then 4 again. That's much less than if you test everyone individually, okay? So by pooling, throwing together samples and then test at a low prevalence, you gain a lot, right? Now, this is an old idea. As I said, it was invented during the Second World War, I think. And in the context of COVID-19, there's an archive paper that discusses that in particular. But, and I got this idea from a proposal from the US, actually from Cornell University, that suggests to investigate the feasibility of massive screening of the entire US population. They say with a few million per day you can actually do, or per week, a few million per week, about 1 million per day. That's consistent with my estimate here. But if you talk to the people who do testing, they tell you that this pooling idea is very nice, but actually this COVID-19 virus is very badly behaved, and you cannot just throw samples so easily together. Whereas for, say, influenza virus, this is easily possible. Apparently, here it doesn't work very well. So far, this is an open research topic, how to manage that you can really be sure that you will detect an infected person among, say, 60 others. So far, it has worked only for half a dozen or so. But that might eventually be a big leap forward if we manage to do pool testing. So that's just to take you a bit the fear of big numbers of tested people, but we are not yet there. Now I want to talk about the main subject of the talk. So before I discussed the massive screening, which would suppress K, now we say, well, we do whatever we can to suppress K, but we also want to know whether we do too much or too little about it. And so we want to measure it, okay? And the idea is very simple. So we want to get to a situation where the growth rate is 0 or where the reproduction number is just 1. And that's our sweet spot. That's stability without too much pain for the society. Okay, and now we propose the feedback and control loop, as every engineer knows. So say if you want to stabilize temperature in your room, then you measure what is the temperature. If it is too high, you go to the thermostat and turn it down a bit, and then it becomes cooler. You measure again, and you adjust. And the more quickly you can measure, the better. The more rapidly you get the result that you want. I know when I was abroad once and I had a shower that had the hot water supply like 20 meters further away, and I had to find the right position of the water handle to get the right temperature. That turns you almost crazy, because you always get too hot water, then too cold water, and you never know how to adjust. Whereas in our faucets, where this is immediate, you immediately get your result. So the delay time is a very important quantity. And that's exactly the problem with corona, that the delay time between an infection and a symptomatic emergence, say at the hospital or at the doctor, is very large. And that means an enormous delay in measuring. So what we would want to do here is that we have a certain goal for this growth rate. Usually it will just be that it's essentially 0, but you can also generalize that a bit. If it's too big, then you will restrict. If it's too small, if it's negative, then you can release. Then you adjust your measures, and then you do testing again. You measure your growth rate and you react again. Okay. So have we been doing that? Well, no, actually we have been almost in blind flight so far, or at least we have been like driving from the back seat with rear view only. Because, well, what is done so far, and that's just the only thing that you can do, is that you say, well, there's a basic reproduction number, and then you make your policy measures to reduce it. So there's a time varying reproduction number, this R or K of T, okay? And there is infection time distributions, there are time distributions to get symptomatic and to go to the hospital, etc. And in the end, you will have some people that die, some people that go to the hospital, and now you can look what are these numbers of infected people and of death numbers, and you fit those to your modeling of this whole process, right? But the problem is that between a person getting infected and maybe dying, the typical time is 3 weeks between showing up at the hospital, maybe 10 to 14 days. So there's a huge delay here. And not only that, the modeling of this whole process is quite complicated. So there are many parameters that go in there, and they are not known. So you have to, the better your modeling is, the better results you get, but actually you don't know exactly what you are, how good you are, right? So there are many groups that do this. One famous group is the one from Imperial College under Neil Ferguson, and they have a web page where they make retrofits or post-diction, for example, of the number of infections as a function of time. Here you see the data for Switzerland, and that was obtained from fitting death numbers in Switzerland. And here you see the exponential growth. There was some measure taken here, and then it grows further. And here is the famous lockdown, and now the exponential decrease since then. Okay. Now, what they did in this modeling is they said, well, as long as the policy measures that were taken didn't change, well, there should have been a single reproduction number or a single k of t, so which doesn't depend on time, and it only changes with when you take certain measures. So on 2nd of March we had some restrictions, and then further restrictions here, and then a full lockdown here. And you see that the fit shows you that the reproduction number went down and eventually dropped below 1. Okay, so you can say it seemed it has worked, but the caveat is that you know all this only after the fact, right? But also, if you now go to other groups that model this stuff too, then you see that they get quite different results in the details of, I try to align it, but it's not quite possible. But what you see here, first of all, the overall scale is not the same. I'm not sure whether this depends on the choice of gamma, of this serial time or so. But then also an important detail, or not really detail, but really important is at the lockdown, which is here, I think, this model, the lower model, suggests that the R factor was already at 1 a few days before, essentially. This modeling of the Imperial College group says no, it was still around 2 or at least above 1.5. So such, of course, this is a short time, and of course the error bars are kind of big, but these are enormously important details. So you want to know whether you were close to 1 or close to 1.5. And you see that the modeling seems to matter. Now, who is better? I really don't know. But the fundamental problem in any case is that there is a delay between you knowing what is this R value or K value and the current date, right? So that is there in any case, and then there's a problem of how to model best. Now, why is this delay so bad? So if you have an undetected doubling in 3 days, that would be the worst case where you don't do anything. But just to take an example, so if you wait for 14 days and you double every 3 days, then you have an increase of the infection numbers by 10 to 30. That's an enormous number, and so it would destroy the whole thing that we gained now during the lockdown in just 2 weeks, if that happens, say, after the release of restrictions. Probably it will not be as catastrophic as that, but still an increase by a number of 3 or 4 is already bad, right? So now a few more details here, but then we will go on. So just to show you, this is from the web page of the Swiss National Task Force, and that's the data obtained from the fitting of Tanja Stadler's group. That was the lower one on the previous slide. You see, depending on which numbers you fit, whether you take deaths or hospitalizations or confirmed cases, these are the 3 curves here, you get different answers for what was the reproductive number as a function of time, and then the error bars are relatively big here, and the overlap is so-so. But what is important is this enormous delay here for 14 days, essentially. And another important thing is when the numbers that you fit to are small, then the error bars are actually pretty big here. And the result, as I said, depends on how you model and how you fit. Okay. But this is the most important fact here. You can look at what other groups in Switzerland do, and you can compare what they get out. And I just want to say they always give confidence intervals of, say, the reproductive number or the effective reproductive number, and you can look at these confidence intervals, and what you will see is that they don't overlap. So it tells you that the values that you get out are pretty well known, supposing that the parameters that you put in your model are perfect, right? But if you take other parameters, you will get other numbers, and you know them also very well, supposing that the new parameters were perfect. But what it tells you is that these parameters are not perfect, and then you don't really know that well what are R values, etc. Okay, so that's the uncertainty inherent to this modeling. Now, can we do better? In particular, can we avoid the 14 days delay, and can we remove modeling uncertainties? There better data than hospitalizations and detected infections and so on? Well, the answer will be yes. It costs a little bit something, but I think we would gain by improving the data. Just to illustrate you once again the problem of these delays, here I show data from Geneva that we focus on later on. So here's the lockdown. These are deaths per day in Geneva, in the canton. And you see at lockdown, you could maybe guess that something is increasing, then you take a measure, but then for 3 weeks, it still exponentially increases because the deaths come 3 weeks later than whatever you do. The effect only comes after 3 weeks, and that means you have here an unmitigated growth, even though you're still in lockdown. So this rose up by a factor of like 15 or so, as we said before. So you have a huge iceberg still hidden when you just look here. And what really comes, you will only see 3 weeks later. And that is the problem of all this delay in the data. Now, what would be the benefit if you had a shortened delay? So if you didn't have to wait for 2 weeks until you know what is your growth rate currently. Well, look, here's just an illustrative plot. Here's time on the x-axis, and on the y-axis you have the prevalence, the fraction of infected people. So first we had this growth, and then it was getting catastrophic. We had the lockdown, and now it was decreasing exponentially. Of course, much slower than it was increasing here, because that costs a lot of effort. And now, if you have a long delay, and say here you start to open your economy again, or you're opening schools, you may have a certain increase, exponential increase again, but you don't know what it will be, whether it will be like this, where you are relatively lucky, or whether it will be steeper like that. But you will have to wait for 2 weeks until you know. So this can, if you're unlucky, it can increase by a factor of 10 or 20, right? And if this is supposed to be safe, you have to wait until you are down here, right? Below this green level, which is the level that your health system can manage. If you start earlier and you're unlucky, then you will have a disaster, right? If you have a delay time of only a few days or maybe a week, then you gain a lot, because you could in principle start earlier if your goal is just not to reach that manageable limit. That is the second point I mention here. But what is also very clear is that if you have to wait long and you increase here, then the amplitude of how much it goes up and then it goes down again and up and down is much bigger than if you can react fast. That's like with the water temperature example. If you have to wait long until the water gets hot, and you do something and it heats up too much, then it will be super hot afterwards. Then you turn back, and then it becomes very cold. If you have a very fast feedback, you can keep this amplitude much smaller. Okay, so short delay is something very good to have, because things are much finer controlled, but also because you can shift the time where you start reopening earlier, if you think it's ethically okay to have a prevalence that is higher up here than down here. Then that's up to society to decide. Okay. Now, the basic idea is very, very simple. So if you can do that, then you gain something. And now, how do you measure this K and have less delay in knowing what this growth rate is? Well, the idea is that you test people randomly every day, and you just measure what is the prevalence or the infected fraction of people, and you look how this evolves as a function of time. So let's suppose you sample over an interval of delta t and you split this in two, then in the first interval of time you will find number of people tested times the fraction that is infected times the length of the time interval over 2. In the second half of the time interval, it will be exponentially bigger with this k that you want to measure. From these two expressions, it's simple to extract what k is. It's just basically the logarithm of this fraction divided by delta t over 2. Of course, this comes with a certain uncertainty because these numbers n1 and n2 that you will detect, they are not fixed numbers, but they depend on who you happen to test. And so these are random numbers, and so this has fluctuations, and so this is not an exact predictable thing that comes out, but it has an uncertainty. And that can be obtained from the law of large numbers, what this uncertainty is. And the more you test, the smaller the uncertainty is. Okay. Now, as soon as you're certain that your growth rate is, say, positive or negative, then you know you can actually intervene. You should do something to reduce it closer to zero if it's positive, or you can release restrictions because you're too strict on your population. And you can simulate that and you can show that it works depending on how well you know what the effect of your measures will be. You will converge either very fast, like here you see in the dashed blue line. You see how you get to a very stable state with a growth rate that converges as a function of time pretty quickly to a very stable situation. If you know much less about your policy measures, then it takes longer and it takes more deviations. Anyway, but that's a kind of a physicist's decoration of this main idea. Now, the intervention strategy that we worked out is that if your fitted k value, the growth rate, is bigger than 3 times the uncertainty, you can intervene, and then you will get a good policy strategy. But just for say, without all these details, you just have to understand that things work well if on every day you find a few detected infected people. And that means that you should test the number R per day, which is a handful divided by the current infection fraction, the current prevalence. So if the prevalence is 1 in 1,000 that is infected, you should test at least about 5,000 a day. Like that, you will find typically 5 people infected per day. And after a few days, you will see whether this number grows. It will fluctuate, but you can tell after a few days whether it grows or whether it decreases. Okay. Now, what we show here is that the more you test per day, here it's in units of 10,000 a day. That's quite comfortable if you manage to do that. First, the time until you intervene, until you can react to a sudden growth, becomes much shorter. So here the times are relatively big because we imposed a rather high accuracy goal to know when your growth is really positive. We can decrease that and still do well, and then this time goes down. You decrease the health cost. That means you decrease the amplitude of oscillations of infected people. You decrease economic costs, and you decrease also the number of interventions. But it is mostly, say, this fact that you can intervene very quickly if you test enough that controls the whole use of the thing. Okay, now you probably wonder, now what is exactly the concrete benefit of random testing versus just measuring this k with post-diction of based on symptomatic data, namely on deaths or hospitalizations, right? So the most important benefit of such random sampling is the monitoring that you can do when you have a sudden release of restrictions, like in Switzerland we will have on Monday actually, and then next month, hopefully in 4 weeks, right? For Monday, it's probably too late to really start this, but certainly for June, it would be a very good idea do this now. Later, we'll have other occasions when we reopen universities and the borders, and if you want to reallow concerts and so on. Apart from this monitoring of a sudden release, of course, you will also get precise and undelayed information on the prevalence and on the evolution of the disease. And that gives you data that allows to fix certain epidemiological parameters that go into those models that that all these groups are using. And if you can give them more constraints on what the data is, they can fit their parameters better, and then they have better predictability that serves us all too. So there are further benefits apart from just the monitoring of a release. But let's now look at this case where we release restrictions like on Monday. Basically, what random sampling gives you is a huge upgrade from basic health insurance to private or premium insurance, like this. So if you do the little calculation, you see the following. If after your release, your effective reproduction number happens to jump to, say, 1.5, which we don't hope will happen, but it might happen, because we just don't know how much opening schools and so on is going to affect the R number. Now, if you do random testing, then you have a chance to detect that much earlier than 14 days, which you have if you look at just symptomatic test data, right? So if R jumps up here with sufficient random sampling, and it's not even so many people per day, you will be able to intervene earlier, and then you say you go back to more restrictive measures, or even back to lockdown, depending on what you decide to do. But as soon as you see that you should do something, you will do something. And then you can ask, at this point of time, how much has my prevalence, how much have my infection numbers increased since I had taken the release measures, okay? Random testing, then you will intervene basically after 14 days if it's necessary, and you see that by then, depending on what your R value was, you have increased a lot your infection number, and that's bad, because that means health costs and also increased death rate just due to mortality, right? If you do random testing very regularly, you can intervene more rapidly, and if the jump in R is substantial, then you gain a lot in this decrease of the increase of infections, right? Even more drastically, you can ask, how many saved lives will we have per week if we do that? So the idea is that if I have less infection rate in the population and I have a certain mortality, then I will just reduce the number of deaths per unit of time that there will be. And with some modest estimates of prevalences, I got these numbers here. So if you test in a region that has prevalence of 2 in 1,000, like maybe in Geneva is still the case, with these numbers per day, you gain something as soon as the jump of R after your release is above, say, 1.25, okay? Or 1.2, if you test a bit more, you do very well already down here, right? And you see, you save a few, even a dozen lives per week. That means if you had this increase here and you don't manage to get it back very quickly, which would mean lockdown again, if you don't do that, then you lose a dozen of lives per week that you could have avoided if you did do this random testing and you intervened more quickly. Okay, now we don't know exactly what the prevalence is in the population. Here I show you what happens if you have 2 per 1,000. If you have 1 in 1,000, you have to test twice as much to get the same result. If you have only 5 in 10,000, then you have to test 4 times as much, right? Okay. Now, do we know what is the prevalence of the population? As I said, no, nobody knows actually, but we can estimate. Either you go to simulations like from Imperial College, and you will see that they tell you up to now, Switzerland has had maybe 2% of people infected over all time. That tells you at the peak, maybe you had 1% infected, and then you had an exponential decrease. So you can estimate what you have now. That's pretty inaccurate because here you have a lot of uncertainties, but that's about the best we can do. We think in Geneva, the prevalence is probably still high, and that's a city that is highly affected by Corona. So there we know something else. We know from antibody tests that about 5.5% of the people have been infected. That's 3 times more than Imperial College would predict for whole of Switzerland. Now, how does this help you? You can estimate the acute prevalence just before the lockdown by saying, well, about half of this zero prevalence, half of all infected people were probably infected at the peak. That's a pretty reasonable estimate, actually, even though it sounds kind of crazy, but that's how it works with exponentials. So you had maybe 2 to 4% of people infected at the peak. Then you look how this number decreases after the lockdown, and that's typically a halving time between 7, 8 to 10 days. First it was slower, then it became faster. And that allows you to more or less estimate where we are now. Now we were 50 days in lockdown. We can almost not imagine that, right? So the prevalence was the peak prevalence decreased by 2 to the minus either 6 or 5, depending on what number you take here. And so that gives you an estimate of maybe 4 or 15 in 10,000 that are still infected. That matches more or less what we see from detected infections from PCR tests of people that want to get tests. And these were 2 in 10,000 people that tested positive over the last 10 days. 10 days is a typical time of which you are maybe infectious or would test positive. So that would tell you that we miss between a factor of 2 and a factor of 7 of people that are infected. That's this dark number that we don't know. If we did random testing, we would eventually know actually how many we are missing, and that would also be valuable information, right? Okay, but right now we can only have this very rough estimate, and of course how much you have to randomly test to get good control depends on this number. Right. So I think a relatively safe guess for Geneva is maybe 1 in 1,000 right now. Maybe it's a little less. And here you see again what is the gain of a certain number of tests per day. Good. That's the main punchline of our work, and we would really hope that authorities pick up on that and realize it. How much does this cost actually? Well, the cost per tested person, maybe you have heard in the media that the PCR test costs 200 francs. That's only if you go through the health insurance, but if you do that through dedicated private labs and so on, you can reduce this cost. I was told 20 francs should be possible. On top of that, you have to do logistics. So you have to have call centers. The Bureau of Statistics has to make sure that you randomly sample and not do biased sampling. So far, it seems like you have to have test centers and medical staff that takes the probes, even though right now in the UK, we have random sampling that works with self-tests that are sent in by mail, and that would reduce the cost by a factor of 2, at least, I think. But unfortunately, this seems not currently allowed in Switzerland. Maybe there's something one can do about this. Now, where should you test? You test best in places where you still have a lot of infected people. And of course, the Ticino was hurt badly but Geneva even a bit more after time. Lausanne and Basel are the most infected regions. And it looks like the big cities would have the infrastructure to do this random sampling, a bit representative for the whole of Switzerland. So the idea would be you go to such a place, you do the sampling of infected people, you estimate the growth rate, and you say this is probably an upper bound for what you have in Switzerland. I mean, it's likely that in Geneva, growth rate is a little bit higher than, say, in the central part of Switzerland, but it gives you an idea of what is happening as a function of time, and what are the jumps in the R value or in the K value that you can expect. So if you do it in Geneva, you get a good thermostat, at least for Geneva, but probably for the whole of Switzerland. Okay. Now, has this ever been done before, or is this a crazy idea? No, it has been done before, and it has also been suggested by various people, even in Switzerland, but in the US, it has become very popular recently in the newspapers. You read it all the time. The earliest country that did random sampling was Iceland, but that was somewhat biased because it was self-selected sampling, and they found the prevalence at the time below 1%. Austria is quite adamant about stuff like that. So they did before Easter random sampling of about 1,500 people and found 1/3% infected. But now they are doing a bigger study that should probably become available soon. I also saw data from the US. Here's an example, which was quite worrisome, from San Francisco, a very dense quarter in San Francisco. An average prevalence as high as 2%, but in certain subgroups of people who cannot stay at home but have to go work outside, it was 6%. So if you sample there, you have to sample relatively little to get good information of what is going on. The UK is also making a big effort. They test now 100,000 people in the so-called REACT-1 program. That's part of a strategy to mitigate the disease there. Now, all of this costs because you have to test individual people. It's also inconvenient. So it would be wonderful if we could actually replace this individual testing by looking at sewage water. Why that? Because sewage water contains the virus, so it can be shown to be present there. And the hope is that by looking at sewage water sampled over the whole day, say, you can quantify how many people are infected in a certain region. And that is currently being tried at EAWAG in Switzerland. Of course, everywhere in the world, people are trying to make progress on that, and I very much hope it will work, but there are open questions, namely the validation. So we know that the signal is not proportional directly to the infected number of people. But there might be a relationship that you can establish, and if you're lucky, then there's such a relationship and so little fluctuations on this relationship that you can determine more or less what is the infected rate. And if so, then you would be able to really detect in different regions in your country how the infections not only are at a certain time, but how they evolve in time. And then you can react regionally refined. That would be wonderful if that worked. We don't know whether there's a delay between infection and how it shows up in feces, but that's probably a minor problem. I think the validation or the calibration here is the big issue. And we hope that we soon know better whether this will work. In the absence of that, we have to do random sampling of individual people. What is coming up in, I think, 2 weeks from now, there will be a first trial essay in Basel-Land, actually, where at the same time we have sewage probes and random sampling of people, both for antibodies and infections. What we are interested in is the infections and how it correlates with the sewage water. If this is a success, then hopefully one can make progress in calibrating sewage water and eventually dispense of individual testing. Now, just to show you that even in the New York Times, Harvard professors have been asking for random sampling. That's the best you can do if you cannot test everyone, because it gives you an idea of what's going on, and very fast. So we are not alone in saying that. So if you manage to do the testing in one place, you could ask, well, so first there are practical questions of what is the best logistics. Should you test everybody? Should you test subgroups? Should you, for example, test only students or elderly people or people working in supermarkets? These are all valid questions. Probably if you test people that are have a higher prevalence than average, you do better on, you can use less tests to get the same result. But how to do so, that's a matter of discussion. How to optimally test, what would be very nice is if one could do self-applied self-tests via saliva and mail these samples. But so far, I think that's not possible in Switzerland. So one has to think how to do the logistics there best. If sewage works, that would be wonderful too, because then you could do geographic refinement, which with individual tests is probably very difficult, I mean, or very costly. Then you could ask not only for the infection number of one region, but you can label your regions by M or N, and then you can ask how does this evolve in time with a matrix, not only a K value, but a K matrix, and you can fit this K matrix and then ask what is the best thing to do to bring this K matrix in norm below 0. Okay. Not in norm, but you want all eigenvalues, real parts of eigenvalues, to be below 0. Okay, with that, I will conclude. The summary is relatively simple. The message is simple. A modest number of people per day, a few thousand, should be enough to get a good picture of what happens with the infection numbers and whether they grow or they decrease. It significantly shortens the delay in a feedback and control loop. That means you are more efficient in terms of you are faster and you save lives.
I have a question. Can you hear me okay?
Yeah.
Okay. I was wondering what the current capacity is in Switzerland and how much resources we have to do this, even if we can afford to.
I don't think the capacity is actually a bottleneck here. So there are private labs, say, that are different from academic hospital labs or so, that can do tests with certain pooling strategies that easily reach 5,000, 10,000 a day for a single lab, for example. So one has to pay them, but it doesn't jeopardize, for example, the medical use of testing or contact tracing or so. I think the bottleneck is more the logistics and well, the willingness to spend money on this.
So you said 50 francs per person, including logistics. So that's like 500,000 francs to do this properly?
You mean per day? Yes.
Per day?
Then you do a pretty good job, yes. But say with 250,000 per day, yes, you would do well. So that means maybe, let's say 10 million a month, right? Now I showed you that you can save maybe up to a dozen of lives per week, right? In a month, that's 50 lives for 10 million. I mean, if these were cancer patients, you would never ask whether they have the right to use chemotherapy for 100,000 francs, no? So, I mean, it's a bit, I don't want to enter too much into the question of cost versus lives, no? But in the US, people talk about the value of a life being 10 million. So if you even save one person per month, that would be good enough, right? And we are far above that.
So Klaus, you are unmuted. You want to ask a question?
Yeah, if possible, yes. Thank you very much, Marcus. It was very interesting. I was wondering, sort of, you use one parameter set for the whole country, right? I mean, to start with, and then you do random sampling and use law of large numbers to quantify the uncertainty of the random sampled numbers, right? I mean, and I was wondering how sure you are that if you take n, that square root of n is a reasonable uncertainty in that case, because you will have clusters locally and things like that.
Yeah, that's a valid question. I'm actually not totally sure. I mean, so the model assumes that where you test, your population is sufficiently homogeneous, right? So you could, I think the Canon of Geneva is somehow interesting from that point of view, because I think that is somewhat homogeneous. I mean, the population density is relatively constant and so on. But of course, still within the population, you have different strata, right? But then I think you have to sample randomly within that restricted population. So the Statistical Bureau has to give you, well, a representative sample of that population, I think.
So it would be some sort of an importance sampling, and you would have to assume that with the number of tests you do, you will find the clusters as they emerge, right?
You know, I think if it's not a single cluster that emerges in the whole Canton of Geneva, but if it's a few clusters, then you should actually detect them by your random sampling of. If it were one rare event that drove everything, then that would not be the case. But if that were really the case for epidemics, then all these SIR models, I think, would not really work. And usually, on average, they are pretty successful. So I think, one probably has to try whether it really works, or one would have to. One could also try to simulate complicated models where you have this clustering and then test whether these assumptions of, you know, truly random distribution hold or not. And we haven't done that. But so my hunch is that yes, it is somewhat of a concern, but I don't think it's that big of a concern.
Alex, you are unmuted. You want to ask a question?
Yes, I have two questions. So very nice talk, Marcus. So I have a question. In your model, you assume that the politics will react immediately as soon as there is a signal. And okay, this is probably not the case. So there is some time constant. So can one introduce that in the model? And the second is, and after I have a second question. I know that you have been in contact with the task force members and so on. If you can tell us, if it is politically correct, that you can tell us your impression that you have about this task force and the relation with the politics.
Okay, so first, yes, there is always a political delay, but of course the delay is there whether, you know, we basically ask, when you do random testing, do you know earlier than without random testing that you have to do something? Once you know that you have to do something, there will be the same delay, whether it's, you know, whether you come to this conclusion in 7 days or in 14 days. So I don't think, you know, the usefulness of the random testing is not affected by that. But you can say, okay, to have a safe strategy, I have to take into account that politicians will take 2-3 days to think about the results and then take a measure. that you can easily put into your modeling. We haven't done that because somehow that you know, the qualitative outcome is not going to be different. It's just in this detailed numbers. About the task force, well, I would have wished that we would have gotten feedback early on these ideas, and you know, especially because of questions like, you know, do you have to worry about clusters or not? That's questions that epidemiologists know better how to assess. And there has been quite some delay, and now I think we are too late to really implement this strategy for Monday, right? I mean, nobody will put up the logistics for Monday, and I'm a bit concerned about Monday, and I think the task force has also its worries, but we all hope that it goes well. But for June, I think, as far as I understand, there is a willingness to implement some sort of monitoring along these lines. Maybe not the canton of Geneva, maybe it's just school children in Geneva and in Zurich or Basel, something like that. But there are now efforts and discussions how to implement that. Now, I think it requires federal, actually, because for a canton, it's a huge burden to put out a few million per month, say, or just for a few weeks. And that is also difficult because I think the federation burn waits for cantons to make some proposals or do some testing. But the testing is so costly that the single canton will not do it by itself, and so one has to initiate the process somewhere and then find the money, and that is not so easy, I think. But we are working on that.
Matthias, you are unmuted.
Yes. Also, my question is related to this assumption you already have discussed this, that basically the population is treated as a homogeneous body. But there's also another issue. Are we allowed, if you have a random sampling, you say you just pick in an experiment, it's easy, every atoms cannot be denied, but what's about people? If people can be forced to be tested, and if you ask on a voluntary basis, then you get the risk that you have a colored study, because people who think might be affected might come with a higher probability for testing than people who don't think that, or from certain groups who might be groups in risk, and that might give you rather an upper bound of the infections in the population than.
Yeah, that's right. But so I wouldn't trust, you know, the prevalence level, that this is a very precise measure of the prevalence, if and since you cannot force people to get tested. But in Austria, 75% of the people who were randomly contacted complied, and in some other areas even more. And I think this bias of who goes to the test and who doesn't is not will not evolve with time, I think, or very little so. And so if you take ratios of numbers, then this bias sort of drops out. And so if you are interested in the growth rate, then you're kind of safe. If you really want to know, do we have 1 per mil or 1.2 per mil, then that is very difficult to get from such a random sampling. That is true.
Thanks.
Are there other questions?
Yes, I don't know, can you hear me?
Yes, we can hear you.
Right, my name is Marcus Carlson. I'm joining you here from Sweden in my house. So as you may know, Sweden has taken quite of a different path, and we haven't had any lockdown and very few restrictions at all, to be honest. And based on these SIR models and so on, I have some colleagues in epidemiology I was very much against that a month ago. Well, I still am, but that's beside the point. What surprised us a lot is that these models, at least for Sweden, turned out to be very wrong. So we seem to have an R value here around 1 at least. The deaths are stabilized, and that surprised everybody. And also some studies that are still underway in Stockholm seems to indicate that the spread is extremely uneven. So you have pockets with a lot of spread, and then you have big parts of the city where nobody is infected at all or have been infected. So that made me start thinking whether these SEER models are at all applicable for this disease, because they kind of assume that everybody as individuals behave the same, right? So each individual transmits to a certain amount, but that doesn't seem to be the way this disease is spreading from what I can see here. So this is my question, just if you have any comments on that.
Can you say again which model was proved wrong? As say, you say the R value is 1 instead of, I thought Imperial College, for example, measured 1.2. Is that what you refer to, or?
No, what I'm saying is just that so the Imperial College, they modeled with some variation of this SEER model, and also some Swedish epidemiologists did that. And in both cases, the expected amount of deaths by now is much, much higher than what we are actually seeing. So I'm not saying it proves it wrong. I'm just saying that this disease doesn't seem to follow this prediction at all, and maybe it's inside the model. That was just my general question. If you have some comments there.
Okay. Yeah. So I think, you know, all these models that are used to do this post-diction, they have a lot of parameters, right? There's a distribution of times until between infection symptoms, hospitalization, etc., etc. So you have enormously much freedom how to model things, because you don't actually know all these things, and then what you predict from that will also depend on all these models. So we want to be kind of free from that, and we just said, well, in some sense there is a differential equation of this form, di dt equals k times I. Or you can say, well, there's not a single I, but there is somehow, you know, there are different groups or different classes of people that behave differently, and so there's a crosstalk between these groups. And so there's an exponential growth, or maybe there are several modes that grow exponentially with different rates. But overall, there's a dominating growth, and hopefully you can, and the idea is how to pick that up. Now all the other details of who gets sick and who is going to be healthy and who is dying and so on, that's out of our concern. We just want to know, is something growing exponentially, and we want to know that fast. So by stripping down all these details and just asking about sort of the dominant eigenvalue, if you want, you know, we are not predicting how many people will be dead. We just want to know, is it growing or not? So you know, and I think that's an interesting trade-off which we get here.
Okay, well, thank you.
Yeah, I do not see any more questions. So thank you, Marcus, for this very nice and inspiring talk, and I hope that the policymaker will have a big ear for our models. Thanks for joining in, and have a nice afternoon.
It's all